And another time I can tell you about those justice investments. Behavioral health workforce. So in addition to that rate increase for Medicaid, we actually got money to support other initiatives so we can build a behavioral health workforce. Not going to talk about that today too, but we're focused on direct support professionals, things like recruitment and retention, mental health professionals. So besides rates, we actually have to do something to attract them beside rates. So we're looking at loan forgiveness and incentive programs to get more licensed folks into the field. And some of that money too are for state facilities. Many of you spend a lot of time talking about really our problems getting enough staffing to maintain enough open beds in our state facilities. So a nice chunk of that money is actually for recruitment and retention of state staff at the state psychiatric facilities. Again, that's our most complex patients. And we actually have one of those facilities is for children. It's Whitaker School, if you've ever heard of it. Of all the psychiatric residential treatment facilities in the state, it's certainly the most expensive, but it is the best. So that's a good thing. We're paying for really good care. It is the best, but that means and children do very well there. We don't want children in that level of care, but we've only got one Whitaker School. It's expensive, and we need to maintain it. We need to up all children's services, and I'll talk about that later on too. But then we got $80 million. Thank you for child and family well-being. And that's the bucket I will talk about the most. I'm going to talk about crisis services in particular, but what we're doing for that whole continuum of services for children and families. Okay, so let me start with, please work. Just telling you how we're going about the investments. I promise I'm pressing. There we go. I just want to tell you about our approach because I actually think that's really important. We completely recognize our role in the public space. Our job is to work with the community. These are public dollars. And so our approach has been to work with the community and be as transparent as we can. For all of those funding streams, we established community advisory committees. We meet every month. We gather information. We meet with providers in the community. We talk about the holes. We meet with counties. We meet with LME MCOs. Depending on what the funding is, we meet with Office of the Court, Sheriff's Office, emergency departments, just to make sure we're listening to the community about where our holes are. So transparency and engaging the public is important to us. We're also trying to use data to be smart. I'll show you a very specific example later on where we are putting some of our crisis funding in counties that have the highest rates of people languishing in emergency departments. So we're trying to be smart, right? There's only so much money to spread around. We need to target the dollars to where data is showing us that we need it the most. But we're also tracking success right from the beginning, right? If we're going to open up a crisis facility, for example, we should expect, A, that it's being used, 2, that the people are going there are going into community services afterwards. 3, they're not repeatedly in crisis. And 4, overall, we're seeing emergency department utilization down. And for kids out of home placement going down. So right from the beginning, we're saying, as we invest, let's start tracking our pain points and making sure things are going in the right direction. So that's just been our approach to using the dollars. Because also we fully expect, like today, we fully expect to come back in front of you and account for ourselves. We need to. This is big money, and it should make a difference in our communities. The other thing I'll tell you about approach is the money is for 2 years. I don't know why I can't make these buttons work. Maybe I press something else. But as we're working on the buttons, the next slide is going to tell you about our 2-year approach. So year 1, we were really looking at things like shovel-ready projects, right? Things we could get in, money in the community, get it going immediately, while at the same time doing our research on long-term sustainability, right? So we're trying to fund things, for example, now that were shovel-ready, where we could upfit buildings that were already in existence, right? And also, should I do that? Do that? Okay. And does that make it go backwards? Okay. And we're also thinking about, like, yes, we're funding something, but that is a Medicaid billable service, right? We're funding this facility, and then Medicaid can reimburse for the services provided in year 2. From then on, once we build a facility, if you will. In year 2, we are looking at our current programs. So year 1 is about a lot of new startup, right? An infrastructure, thing that we can't typically pay for, upfitting a hospital or upfitting a wing of a crisis unit. In year two, we're looking at existing facilities, right? Because even though we're opening up more crisis facilities, there are existing crisis facilities. We need to make sure those are warm, inviting places with updated technology and space for the consumers that come to them, right? So we're going to look at updating current infrastructure that we have, but also that really continued focus on long-term sustainability. I spent a lot of time thinking about long-term sustainability. I mentioned the behavioral health rates already, so don't need to belabor that. Very excited about those. Now I want to talk about the crisis system as it pertains to children. So that's a very busy slide. So let me explain it this way. We're all very familiar as people with our current 911 crisis system, right? Anybody knows to call 911. Isn't it amazing, right? And law enforcement, EMTs, firemen all come out together. How many of you have called 911? I sure have, twice. I had to call for my son and my husband, right? Terrible. My son was like 7. It was the most horrible thing in the world. They were there within 5 minutes. I will forever be grateful to them. They were able to take my son in an ambulance to Children's Hospital at Wake Med, right? So we have a well-oiled kind of infrastructure. I knew who to call. They got there really quickly. They were able to take my child to a wonderful facility, and everything was ultimately okay. So it's a well-oiled machine that we all use and we all expect. Our mental health crisis system is not so well-oiled, right? People can wait really long when they need a mental health crisis response. And in the slide, I'll explain even what that is. It's different. It's not the same as calling 911. It's not the same as having an EMT or law enforcement come to your home. So it's different. That's very uneven. We don't have enough mobile crisis teams that come. We prioritize in our state, IVC. So pretty much when people come, they get involuntarily committed to hospitals every day. We utilize it quite a bit. We don't have a lot of voluntary commitments. Crisis services are really uneven. You may be sitting in a place where you're like, I know I have a crisis facility, I trust it, I'm a county and I funded it. And others of you are sitting here saying, what's a crisis facility? Why don't I have one? I really need one. That's kind of how it is. There's not a lot of them. They're very hard to maintain and sustain. But even then, if you have a crisis facility, yours probably looks like no one else's. If you have a crisis team, yours probably looks like no one else's. And let me ask you this. Would you even know how to call your crisis response company to come to your house? Nobody does, right? Yeah, I mean, there's just so much about it that doesn't work, right? You may not even know that you have a crisis facility in your town. A lot of people don't. They don't even know where it is. But I bet you if I asked you where your nearest urgent care was, you could probably tell me. I've got 3 within 2 miles of my house. Not behavioral health urgent cares, mind you. My nearest one is in North Raleigh. I do know where it is, but I know where all my urgent cares are. Everybody does. They're well advertised, but not my behavioral health ones. It's very under-resourced, our mental health crisis system. So this is the continuum we're trying to build. And this matters a lot to kids. So just imagine a situation with a kid, right? Like imagine this in your life, right? You've got a 14-year-old, and the school called you because, a friend mentioned that your teenage niece had cut herself and said that she didn't want to live anymore because she was being bullied in school. What the heck do you do, right? And that is a very real reality that people find themselves in all the time. So what do you do? Anybody could find themselves in this situation. So we're trying to make sure that we have a nice crisis system. And how many in those cases would you call 911? You wouldn't, right? But sometimes schools do. They don't know what else to do, right? They need to get somebody help right away. But what we're trying to make sure that we have is a 3-part system. Someone to call, someone to respond, and a safe place to go. Is that not our medical crisis system? It is, right? You call 911, EMT, law enforcement, and fire come out, and if they have to, they transport you to the nearest hospital. It's the same system. Ours is probably decades behind our mental health system. It's very homespun. It's very different. It's not institutionalized. There's no public infrastructure or funding that continues to support it. So there's a lot. But this 3-prong model is a national model, by the way. All of my fellow mental health commissioners in other states, we're all building this. We either have it or are building it. So someone to call. We have someone to call now. Hopefully folks in the room know 988. 988. Okay. Use by youth continues to rise. The number one reason people call is for a family member. That's actually the number one reason. And it's not crisis, by the way. Only 12% of the calls that come in are crisis calls. Number one reason is a family member calling on behalf of a loved one trying to find services. Next two issues are depression and anxiety, most common things in the world, right? 12% are calling in crisis, only 12%. So vast majority of people are actually just looking for someone to talk to or looking for services for a loved one, which is typical. So that young 14-year-old niece of yours that I mentioned, call 988. They can actually help you find an appointment. It doesn't have to be a crisis visit. They can actually help you find an appointment. So 988 is wonderful. We also have a peer line. One of the things we noticed is that 40% of people calling the mental health crisis line were repeat callers. They call all the time because they need someone to talk to. When I show you numbers, you might be startled when you see how many people are using these lines. So because 40% of callers were repeat callers, we set up something called the Peer Warm Line. It's for 18 and older. It's exactly what it sounds like. It's where you can talk to a peer. It could be a person peer, a family member peer, someone who knows what it's like to navigate the system, knows what it's like to deal with mental health issues, and they can help you figure it all out. People love it. I'll jump to my punchline. 8,000 people a month call 988, 8,000. 5,000 people a month call the Peer Warm Line. That's a lot of people, y'all. And I'll show you the map. I'll show you where they're calling. They're calling from everywhere. And the more we market it in schools, we market it other places too, but I'm trying to stick to kids and families. The more we market it, the more people call. Our chat and text, 98 also has chat and text function. We're up to 2,000 a month now, and those are all from young people, all of them. Adults are prone to call, all the youth, all the chat and text are youth. So people are really using this line immensely. Someone to respond. We have things called mobile crisis teams. If you don't know what they are, they're literally unmarked car, trained mental health professional can come to your home. The theory is they de-escalate the crisis, help you stay home. Actually, don't want you to go, but if you have to go, you can go. We have special teams. We have special teams called Mobile Crisis Moors. They're for kids. We only have them in 7 counties across the state, but these are cool. These teams go out in unmarked cars. They're there for families and kids. They not only de-escalate the crisis, they're able to stay with the family for several days afterwards. I mean, they don't move in, but they're able to stay with them. They don't leave. They connect the family to services. So it's a really cool model. And in states who are using it, like Rhode Island's our biggest state, they've seen already a 25% reduction in kids going to the emergency room, period, right? So mobile crisis teams are really important. Co-responder models are really important too. I want to give a shout out to all the counties, all the local sheriffs who do co-responder models. It's freaking amazing. So we have so many law enforcement officers that are CIT trained, so they're getting trained to deal with mental health issues. They're hiring their own social workers. We're getting funding out because as much as I want an unmarked mobile crisis team to go everywhere, guess what? Lots of people are still going to call 911. They just are. We want to make sure that our wonderful friends in law enforcement have mental health supports when they go out on calls because so many calls are mental health related. We want to make sure they have tools when they go out. So we're going to continue to fund more co-responder models. And then lastly, somewhere to go. Behavioral health urgent cares. Nobody funds those except the public space. Nobody. And it's an urgent care, just like anything else, but it's specifically behavioral health focused. They're open 24/7. Some communities have them, some don't. But can you imagine if you feel like not well? You have a loved one, you don't know what to do. Take them to the urgent care, just like you would for a medical issue. Again, you might not know you have one. They are expensive to be operating 24/7. And a lot of people just don't know where they are. Mention that. We also have things called facility-based crisis. It's a terrible name. We're starting to call them community crisis centers, but they're little freestanding, almost like psych hospitals. Don't get that idea in your head, but it's like 7 to 12 beds. A lot of times they're with a BHOC. So imagine you're in a BHOC. You've been there for 20 hours and you're like, I think me or my child needs to stay a little longer. They can just take you down the hall and you can get admitted to one of their beds. They've got nurses, psychiatrists, social workers. You don't have to go to the hospital. You don't have to get transported. You can stay there. It's only, they're small. There's like 12 beds. There's children and adult ones. Sometimes it's 2 different wings. They're very small. They're in community. They're behavioral health staff. They're trauma informed, you're getting treatment. Typically, those providers also have follow-up services, so when they discharge you, they can get you right into services. But that's so much better than someone sitting in an emergency department for weeks and months on end, waiting for an inpatient bed somewhere. We can get them funneled to an urgent care, a community crisis bed, way better than going to a hospital. Not that there's anything wrong with hospitals, we just don't have the capacity and emergency rooms for people in crisis. Okay, like for real, I'm probably going to offend an ED doctor, and I don't mean to. I really don't mean to. I'm grateful for emergency rooms, right? But if you're in a mental health crisis, guess what is not a calming environment? Emergency rooms aren't always the most calming of environments, right? They're busy, they're saving lives, there's a lot going on. And people with mental health issues or past trauma can find those environments particularly distressing. Not that there's anything wrong with an emergency room, but it's not the most therapeutic environment if you're in a mental health crisis. Okay, so there's a slide, you can take it, and it's just talking about the typical system now, where people call 911, they get transported in an ambulance or in the back of a law officer's vehicle. They get admitted, maybe they sit in the ED for, heaven help us, 2 weeks, and then they are fine, they're stable, so they go home with no services. We really want them to call 988 to dispatch a mobile crisis team if they have to go to an urgent care or a community crisis center. That's all. We're just trying to build a more sane system. These are our investments with the money that y'all gave us. This is just year one investments. We are adding 44 new beds for kids, and that number for adults is actually wrong. We're adding 70 new beds for adults. The darker the county, the more people waiting for care in emergency rooms. So those are all targeted towards places where we have high incidence of people just waiting around for services. And here's what we envision. We envision being able to advertise these services where they are in communities, right? We want these to be places where if 911 is called, EMT can drop folks off, law enforcement can drop folks off, right? Because people are going to call 911, but we want people in the community to know where they are so they can go. But this is the way we're using data. So we looked at emergency department utilization, but there's actually a national formula that talks about just things like population density and patterns of care that say, here's the amount of beds you probably need, and here's where they go. So we've used that data as well to make these kind of investments. You will see coming up more investments. Those mobile crisis teams I told you about, sometimes our wait times for a mobile crisis team is 5 hours. That's too long to wait when you're in crisis, right? And I've talked to so many EMTs and law officers who say to me, I called them. 911, I called, and then I called the mobile crisis team and I waited. Well, after I waited 2 hours, I had things to do. So I took the person to the hospital, right? I mean, we just need better systems than that. But it's not really the mobile crisis team's fault. It's very hard in rural areas. And it's very hard when they're not sitting there like in a firehouse model. Many aren't. They're at home. So the call comes in, you have to call a worker has to get ready, they have to drive to someone's house, and that's just not how we want crisis to respond. So we're trying to figure out how many teams we need, but also how to fund them so they're on call 24/7 like EMT would be. We're expanding our 988 center because we can deploy mobile crisis teams from 988 when people call, but we want to be able to track them. So just like when you think about a call center, like a 911 call center, we can see where the nearest mobile crisis team, dispatch them, check on when they get there, what the issue is, send a child team if we need to send a child team, but then know what happened. We don't always know what happens. Did you stabilize the person? Did you have to take them to an urgent care? Did you have to take them to hospital? Did you have to call 911 anyway? We hear that. And that's probably the most tragic outcome. When someone needs to be transported because they don't have a family member, so mobile crisis is there, situation is calm, but they still need law enforcement to come or EMT to transport. You'll see that we're trying to work on that too. We're trying to work on next day and next week appointments because it's good to talk about crisis, right? Because we have a crisis right now. But remember how we said 88% of people are calling 988 not for crisis, they're just calling for services? We need 988 to be able to say, hey, you live in Guilford, right on X, Y, and Z Street, Green Street, right? Is the Monarch open access? Go tomorrow and you can get an appointment. So we already have some of those clinics where people can just walk in for appointments. We're working to develop more of those with this funding and make sure 988 is well connected to them so we can get people in appointments right away. Because again, we're trying to avoid crises if we can. We are talking about teen-specific resources because remember how I mentioned once we added the peer warm line for adults, 5,000 more people called on top of the 8,000 that are already calling? We're looking into, is there any specific support? We still want teens to call and chat and text 988, but are there ways that we can actually offer them virtual services so we can get them into services and talking to a clinician maybe the same night that they call 988? So we're looking at some other states who are doing that. And then many of you are actually involved in the non-law enforcement transportation pilot. So some of you already do this, but we're trying to make sure that when people in particular are sitting in hospitals and they need to go 5 counties away because we found a bed for them, that transportation doesn't have to be with law enforcement. It could be through an EMT, it could be through another vendor, but we just want people, we don't want to gum up law enforcement resources like that. That's just wasting their time, truthfully. But we also, again, that can be traumatic for a person being transported for mental health issues. There's got to be a better way to transport them. All right, so that's crisis. And this is for adults and children. But with all of this, we're hyper-focused on kids in EDs, what a kid's crisis response looks like, what a kid's crisis line looks like, because there are differences. It's going to be slightly different for kids than for adults. All right. So the last thing I'm going to talk about is our child and family well-being investments. All right. So I mentioned there's $80 million in child behavioral health. Crisis is for all. This is very specific to children and families. There's some data that I want to show you, and you don't have to raise your hand, but probably many of you get calls like I get calls every week. You've got a constituent who's got a child waiting in an emergency room or in a DSS office, right? Yes, terrible, just absolutely terrible, all right? So none of us want those calls. We don't want children in the situations. We don't want DSS workers in those situations. We don't want hospital workers in those situations, right? So we are tracking the number of kids in emergency rooms and the number of kids in DSS offices or other placements. So on average, last year we had 54 kids on any given week in emergency rooms just waiting for placement somewhere. 40% of those were in DSS custody, so not all of them, but a good portion. And about a quarter of them didn't just have mental health issues, they had intellectual and developmental disabilities. So for those of you who aren't fluent in that, think it's a child with Down syndrome maybe, or fetal alcohol syndrome disorder, right? So that's who we're talking about, and mental health issues, right? And typically that translates into, think about it, to a child in a room, a child who maybe had 4 or 5 placements as abandoned. Often these children have some kind of acting out behavior, right? And it makes it really difficult for the hospital to manage their behavior. The cool thing is that data is better this year because of some of the things that we put in place. It's not gone, it needs to be gone. But right now we're averaging around 40 kids a week in hospitals. That's still too much, y'all. Way too much, but it's down. And here's something interesting. About a third of them are in DSS custody. So we think some of the DSS changes are making a difference. But a third of them now have both IDD and mental health. So we're learning a little bit that some of our still really challenging to place children have, we know, physically acting out behavior, but kids with developmental disabilities and mental health issues. In terms of DSS boarding, let's look at this number. Last year we had 32 kids on any given week in a DSS office. We're down to, that says 19, but now we're down to 16 a week. And I'll tell you about a specific program that Lisa Colley's here. I'm going to call it Lisa. Lisa Colley's the director of DSS here at the state. Awesome colleague. So they've put in some wonderful programs in place that's really driving down that number, which is exciting. So this is what we're trying to accomplish. We're trying to accomplish less ED visits, fewer children boarding in DSS offices, fewer admissions, but also readmissions to out-of-home placements. And that's any kind of out-of-home placement. But sometimes we see kids in a group home, and then they go up to the next higher level of group home. Then they go into something we call a PRTF, a psychiatric residential treatment facility. They get out for 30 days, they go back in. Like something's not working, right? What's not working either in the system they came home to, the treatment they're getting in the facility. But think about how bad that is for a child. It's horrendous for a child. We're literally complicating and compounding any mental health, emotional issues that they're having, right? So we need fewer readmissions. When kids are in out-of-home placements, we are hyper-focused on that being as brief as it can be. Like, we want kids raised in homes. Like, who doesn't want kids raised in homes? Like, isn't that hard to, argue with? We don't want kids raised in institutions for years, in treatment institutions. And so we have that now. We have kids with very long stays in out-of-home placements, and we need to make that a lot better. So we need more children if they have to be placed out of home because their family of origin cannot manage them, right? Or they have issues themselves they need to work through, whatever it is, or a child needs treatment placement. We would love it to be in a home setting rather than an institutional setting. That's what we're aiming for. These are kind of our goals and things we're going to measure. Like I said, we're going to measure things up front. So I want to tell you about 2 investments, particularly for kids with both mental health issues and in DSS custody. I'm going to tell you about these 2 specifically, and then I'll speak more generally to other investments. But this one is really cool because we think this one is really making a difference for all those children who are boarding in DSS offices. So the department was able to, because of lessons learned from some counties who are like knocking it out of the park, if we give counties some money, they can create emergency and maintain emergency family-based treatments for kids. So these are families who agree to take children with complex needs. We're paying them to wait in some cases, which is an interesting idea, right? But it's created capacity in communities when we have kids with complex needs, kids who get, in the middle of the night, they don't have anywhere to go, or they're in a placement and someone drops them off in an ED, right? DSSs were able to build this kind of capacity in communities so children could be placed in these emergency home settings rather than in DSS offices. So this is great. And it's really making a difference in the number of children who are being boarded in DSS offices. Another thing that is incredibly promising is something called professional foster parenting. So our colleagues at DSS are investing in this. These are paid professional parents. They're paid to be professional parents. So they're not the child's parents, right? They're professional foster parents. It is their job to provide a therapeutic environment and meet the needs of the child. It's very novel, but it's really cool. They get evidence-based training, and we are already seeing good results, not just from individual children, but sibling pairs. And I think that's exciting. So sibling pairs, they're able to keep together, be in these professional foster parent settings, and they're able to be maintained and returned to home. So it's a very small pilot right now, but it's already quite successful. And so part of what our DSS colleagues are going to use money for is to do more of this. All right, let's talk about some other planned investments really quickly. So that was a bit of the high end of the spectrum, right? Crisis and children who are already in DSS custody. How can we make sure we have available parents if a child is in crisis, but also kind of this highest level of foster care parent so we can get the child in a therapeutic home-like environment. We're also backing way up in the community, right? We are investing in more school-based services. Schools reach out to us all the time. Kids are there all the time. Teachers need support. School counselors need support. So we're investing in more behavioral health resources in schools. We are also working to make sure that we have enough community-based services for kids. So remember I said all those people that call 988 for services? We want to be able to refer them just not to any old counselor, but counselors who are actually trained in the best models we know of that really support children and families. Because children are in families, y'all. Like, we all learned this a long time ago. We can't just say, oh, that kid's bad. Actually, it's a child in a family dynamic, and they all need help. So these models of care look at children and trauma within the family and make sure the whole family is getting what we call wraparound care. That's just what we call it. So we have some, and the cool thing is that we have some models of care that are working really well in North Carolina. So all we're doing is saying, okay, it's great in these 7 counties. We need it in all counties. And all DSS offices need to know about it, right? So it can't be like you have to figure out and find services. If DSS is working with a family or a clinician hears about a family, they need to know like right away, oh yes, we have this Wraparound Kids program. We can refer the kid to the Wraparound Kids program. Our DSS colleagues are really working on more therapeutic settings. And I'm not the expert, Lisa's the expert. It's not easy. It would be fibbing to say it's easy. One of the hardest things I think we're going to have to do is be able to recruit families who are willing to take and support children with very complex needs. It's really hard. So this is going to take a long time to build, but we're invested in that. It's things like therapeutic or professional parenting, but also therapeutic foster care. And then I already mentioned the emergency placement for kids. So we have those emergency funds if a kid does need emergency placement, so it's not in a DSS office. And I mentioned too the last thing about residential level of care. We have kids in things called group homes now. You've probably heard that term. You've probably heard group home 3s and 4s. Does anyone even know what that is? So kids are in group homes. We need to make sure that those group homes are safe, clean places. You've probably heard Senator Bergen talk about the facilities he's visited. And what I tell my staff all the time is, this is how it needs to be. I want you to go to a facility and I want you to say, sure, I'd put my kid there. I think that's a really hard bar to meet, but I think it's important. These are kids. They should have nice rooms and they should have recreational space. They should have staff that are competent and kind, and we should make sure they're getting the best treatment they can, and they should go home as soon as they can. So that's kind of the standard that we're trying to create in our residential settings. That will take a long time, and we're really committed. It's not on the slide, but we want North Carolina kids to stay in North Carolina. And that means we're going to have to build enough capacity for children who can be aggressive sometimes. You might be too, if this is the 15th placement you've been in your young life, kids who have intellectual disabilities and mental health issues. Pretty complex. We need to build that capacity here in North Carolina. So we're exploring how on earth to do that now. So I could talk a lot about these children's services, but if you want this presentation, we just put this up because it's actually really important. Again, I think transparency is critical. We work for you all. We work for the people in North Carolina. Every month we host a webinar telling everybody what we're up to so they can comment and ask questions. For all of this money, we have advisory groups. So we welcome anyone being involved at any time. So I'm happy to take any questions. I know you, Garrett, I know you're very low on time because you've got to vote, but Mr. Chair, whatever you like, you tell me what to do.
You did an outstanding job in a short period of time, and I think we all the better with some of the information that we can carry back to our districts and share with our constituents. At this time, I'm going to ask the committee members if you have any comments or questions at this time. Mr. Chair.
Yes, sir. Ma'am, I noticed the peer support, and introduced a bill for emergency personnel to have mental health, because we know in my career in emergency services that the telecommunicators, fire, EMS, law enforcement, and folks have some issues, or you have a specialty group that can address their needs mentally and help them with that, or is it just for children?
Oh, thank you, Mr. Chair. That is such a wonderful question. In this particular funding, we don't yet, but we also have other funding sources, and we have something just called our mental health block grant. We get money from the federal government, and part of what we're using the block grant for this year is care for caregivers, and that's in two different ways. So we're actually putting out funding for communities to apply for, and they're really in two buckets: for family caregivers and sibling caregivers, because they need support. It's really hard. They actually support their family members more than we do professionally. But then we also want to give money to EMTs, law enforcement, clinicians, because for programs that support their mental health and well-being, because that's a real issue. So I forget, I feel like it was Greensboro, and I don't mean to speak out of turn, but we met incredible police department, and they were telling us about the program they have to support their officers and their family members. And so that's projects just like that are things that we want to fund. So yeah, that is something that we absolutely want to fund. It's so we have lots of programs for adults and caregivers and everything. So yeah.
Representative Smith, stay right there.
Okay.
Thank you, Ms. Crosby. I really appreciated your presentation. Early on, you mentioned funding for the Whitaker School. I assume that's a state-owned PRTF.
It is.
Is there any funding available for, I guess, privately owned PRTFs, or just the expansion of PRTFs across the state? From within my legal experience, I've had some exposure here, and with Cape Fear Valley down in Fayetteville, I know there have been instances where a child has been in DSS care, but to be involuntarily committed, there's a pretty high standard.
Yeah.
And once that child no longer meets that standard, the hospital is wanting to release them, mainly because they need the space and the bed. Certainly DSS, and the child's in DSS care, DSS, and the child requires a level 4 PRT, level treatment, but there's no beds. And certainly the DSS workers aren't equipped to manage that child. And I saw the emergency fund for the DSS and local DSSs, and that's great. Or there is a bed, but it's out of state, and that's really, really challenging for a parent, especially if the child's in DSS care. I mean, you want to arrange visits and make sure that parental bond, remains. But if you're having to coordinate virtual visits, or that's the best you can do, I mean, that's just a really, really large strain on that family. So is there any funding for the expansion, I guess, of privately owned PRTFs, or funding for the PRTFs that exist to grow and acquire more beds, be able to house a greater number of youth?
Yes, sir. Thank you so much for that question. In the $80 million, we've set aside $20-ish million for PRTF and residential level of care. Part of the money is going out, about $3 million is going out to current PRTFs to improve residential and treatment space for kids and existing. But the other 20, We're actually looking at where we need capacity and specialized capacity. And we're trying to be really careful because we want it to be in-state. We know that we have good in-state providers. We know some of the barriers they've mentioned as to why they won't expand, as to some of the concerns they have about supporting children with more specialized needs. But we know that, like, in 10 years, I want to be able to say, actually, we have a smaller footprint in PRTF. We have enough community-based services that we don't need them. But in the short term, we've got hundreds of kids out of state because they have complex needs. We still got those 40 kids in EDs every day. And most of them, their disposition is PRTF. So we do need to build in-state capacity. We just want to do it like super, super carefully. So we're analyzing that right now. But we do have some money for some in-state, building some more in-state capacity or expanding current providers. So they can, add a wing, a specialized wing and things like that. So yeah, we know we need the capacity. Yeah.
Representative.
Thank you, Mr. Chairman. When we was talking about your 131 million you have in your crisis systems, is there anything within that area that when you have a consumer that goes into or that has an issue and it refers them to something, a program within that crisis system, and the consumer is privately insured to address billing that private insurance to help offset some of the costs of the thing?
Thank you, Representative. That is my favorite question. So I need to answer really carefully. Right now, the only major insurers that cover our crisis services is Medicaid. And with the very generous state dollars you guys give us about $300 million in state every year. It goes to the LMEs. But for that, they have to cover every amount of uninsured or underinsured. And what's interesting is we call other insured people who go for crisis services underinsured. So these are us. Their insurance companies don't pay for crisis services. So this morning, believe it or not, I met with all of our Medicaid insurances, but also a group of private insurers. And I started my plea to say, y'all, your folks are using these crisis services and we desperately need you to help cover the cost. So I don't want to get myself in trouble, but it would be wonderful if other insurers were required to pay for these crisis services that are atypical but absolutely necessary, because it puts a real strain on the very limited public dollars we have when people have insurance and they're using the crisis system. Did I walk that line fine enough?
I think you did a fine job.
All right, thank you, sir.
Representative Green.
Yes, and thank you for your presentation. Just real quickly, you were talking about emergency placement capacity and trying to build out on that. How short do you think you are on emergency placement capacity right now?
With the crisis beds, like those community crisis facilities, literally all our data shows us we need 40 more of those crisis beds. And I think that's really different than DSS placement. So, Mr. Chair, is it okay if I ask Director Lisa Colley if you have any sense about those emergency foster care placements, what capacity we need?
Come up quickly, and we had one public comment, so that person's side, we want to give them a minute to just share. Give your name.
Lisa Colley, DHHS. I don't have numbers for you, but I have populations of children that, should be in family homes that typically we can't find families for. And they are sibling groups. And that's why when you saw the professional foster parenting, they focus on sibling groups. And the other is teens. Teenagers come with their own behaviors, and foster families are much more likely to say yes to younger children than they are teenagers.
Thank you. There was one public comment, a question. They're still here? Somebody have their name? I didn't have it. Yeah.
I just have Kelly Crosbie on this sheet. That's it.
She was speaking.
I must have signed the wrong sheet.
Oh, that's all right. Okay. We want to thank Ms. Crosbie for coming today. Is there anything, I know the chairman don't mind me making this statement, is there any other issue that you, the committee would like for us to prepare? We're going to be here for probably a couple more months. Is there any subject matter or any other department that we want to hear from as it relates to families, children, and aging? you can think of anything, just what'd you say? I saw you smiling. Well, that's what you guys might know better than the peers, but it's not unusual to be here till at least August, so we'll see how that goes. But is there anything else? We want to thank you again for coming today. You did an outstanding job, and this presentation is each member can go online and pull everything down that you chatted today. Anybody else from your group have any comments? Is there another place is there another meeting we can have going forward? Where you started from, there's any other issue that you would want us to deal with going forward? Besides, I know we were with youth today. Is there anything else you think? Children?
I mean, we're happy to talk. I mean, the notable thing that we didn't talk about today really at all were the justice investments, so we're happy to talk more about the justice investments if you'd like.
Okay.
And adults. I mean, we touched on adult services, but there's more adult services.
Okay. Thank you. Yes, if there's nothing else for the committee today, we will adjourn and